Got it.
Sir, we are live now.
Yes.
We can start the session. We are live now, sir.
Live.
Live.
Oh, okay. No.
Hello.
Hello.
Yeah, sir. We can start now. You are live.
Light off.
No, sir. You are live now. You can
Okay,
start the
okay.
session.
Okay. May I start?
Yes, sir. You can start.
From introduction.
Yes, sir. You have to start by introducing yourself.
Myself, Dr. Bharat Parmar, working as professor and head of Pediatric Department, Jadis Medical College, Dahod, Gujarat. First of all, I am very thankful to IJCP group for giving opportunity to me about highlights my views regarding sickle cell disease and beyond. I am working in this tribal belt and the prevalence of the sickle cell disease in this area, 75,000 patients of sickle cell disease here. Last year, I worked as a principal investigator in one cross-sectional observational study of sickle cell disease, and also I gave newer drug, that is injection Grisani-Zuneb. There is an injection Riverna of Novartis company for the management of sickle cell crisis. Newer drugs. I gave this Riverna injection to the 5 patients free of cost by help of Novartis. So I am very much interested in these sickle cell disease here. So today I will highlight my views regarding the sickle cell disease and beyond. So highlights of the sickle cell disease, it includes the sickle cell disease characteristics, Idiopathogenesis, VASO Occlusion crisis as a clinical hallmark of the sickle cell disease, and VASO Occlusion, there is a VASO Occlusion crisis. It lead to organ damage, multi-organ failure and death, and the practical lifestyle approach to prevent vaso-occlusive crisis. And what is the epidemiology of the sickle cell disease? Which are the clinical expression of the sickle cell disease? Which are the long-term complications of the sickle cell disease? And how to approach and which investigation carried out for the sickle cell disease? And what is the management? The management of the sickle cell disease, it includes the hydroxyurea, newer modalities, there is a Grisani-Zuneb. So sickle cell disease is second commonest hemoglobinopathy in India, characterized by the presence of an abnormal hemoglobin, that is hemoglobin S, due to the substitution of glutamic acid by the valine at the 6 positions of beta chain. And the genetic base of this sickle cell disease, there is the deletion of beta globin gene on our chromosomes and the basic genetic defect in the sickle cell anemia, which may be there is a homozygous sickle cell disease, there is SS with a complete replacement of hemoglobin A by the hemoglobin S, and beta heterozygous sickle cell trait AS with the hemoglobin S concentration is 35 to 45%. In addition, many cases have mixed hemoglobinopathies. There is hemoglobin S thalassemia and hemoglobin SC disease. Sickle cell disease is characterized by presence of sickle hemoglobin, there is HbS, chronic hemolysis, vaso-occlusive crisis, there is a recurrent pain. So whenever any pediatric patient here with 3P, there is a pallor, pain and pyrexia, is a hallmark of this hemolytic crisis in the sickle cell anemia. It leads to the multi-organ dysfunction and sometimes there is an early death. What is the etiopathogenesis of the sickle cell disease? In a normal oxygenated state, hemoglobin S function normally. However, in hypoxic state, deoxygenated hemoglobin S develop abnormal coupling of globin chain to deform the RBC in a sickle form. While the sickling is reversible in initial stage, but persistent hypoxia, it leads to irreversible sickling of RBC, which are then trapped in a microvasculatures and spleen and produce vaso-occlusive lesion and hemolysis respectively. So slugging of the deformed RBC in a small vessel further aggravate hypoxia and sickling. Thus, three factors are mainly responsible for pathogenesis of sickle cell anemia. 1. Vaso-occlusive events. 2. Chronic hemolysis, and local as well as generalized hypoxia due to A and B respectively. The pathology of sickle cell disease goes beyond the red blood cell. So traditionally, the sickle cell disease pathology was thought to be due to vascular blockage caused by sickle RBC. So pathology of the sickle cell disease goes beyond the red blood cell. There is a polymerization of hemoglobin in deoxygenated condition. So the morphological abnormality are significantly fully explained vaso-occlusion, since the time taken for hemoglobin S polymerization and sickling of RBC is no longer than in the blood circulation time required for reoxygenation. So there is a vascular damage in sickle cell disease which involve WBC, platelets and endothelial cells. So the current perspective acknowledges the multifactorial nature of sickle cell pathology. So key driver of this vaso-occlusion, there is a neutrophil activation and inflammation, and enhanced adhesion, endothelial activation and polymerization, and it leads to the chronic hemolysis. So pathology of the sickle cell disease and the vaso-occlusion goes beyond RBC. So the key drivers of vaso-occlusion are endothelial activation, enhanced adhesion, neutrophil activation, polymerization, and chronic hemolysis. So there is a vascular damage in a sickle cell disease which involve WBC, platelets, and endothelial cells. Polymerization of deoxygenated hemoglobin X is a primary event in the sickle cell disease, and the pathogenesis of vaso-occlusion is a complex. and hemoglobin S is insoluble in low oxygen tension and polymerize as long as which result in a red cell becoming sickle shape. And VASO occlusion is caused by addition of sickle erythrocytes and leukocytes to endothelium, which result in vascular obstruction and tissue ischemia. And the degree of sickle erythrocyte adhesion correlate with VASO occlusion and increased severity of the disease. So activated and adherent leukocytes are likely driver of VASO occlusion in a collecting venules, whereas sickle erythrocytes may contribute to occlusion of small vessels. So the complex effect of sickle cell disease goes beyond the red blood cells. So there's a vaso-occlusion, chronic hemolysis and anemia, and chronic vascular damage and hemoglobin S polymerization and inflammation and cell activation and sickle blood cell sickling and hemolysis. So vaso-occlusion are a clinical hallmark of sickle cell disease, and VOC may be only the tip of iceberg when it comes to ongoing vaso-occlusion. So VOC clinically visible, VOC can be unpredictable, extremely that last on an average 10 days. So vaso-occlusion, multicellular adhesion, inflammation and cell activation, and subclinical ongoing and often a silent vaso-occlusion occur systematically during patient lifetime, potentially regulating in acute and the chronic complication. In addition, platelet bind to the erythrocyte, monocytes, neutrophil, and aggregate, which contribute to abnormal blood flow in the patient of sickle cell disease. Although the addition of leukocyte to the endothelium and can involve multiple molecules, the process initiated by P-selectin. So P-selectin is found in a storage granules of resting endothelial cell and the platelet and rapidly transform to the cell membrane on an activation of cell during the process of inflammation. So P-selectin that is expressed on a surface of endothelium mediate abnormal rolling and static adhesion of sickle erythrocyte to vessel surface in vitro. So painful VOC are the clinical hallmark of sickle cell disease, and the VOC are a number one cause of hospitalization for sickle cell patient. So VOC event lead to hypoxia, ischemia, and tissue damage, and giving rise to the pain experienced by sickle cell disease patient. So clinical features include rapid onset of the severe pain in one or more joint or extremities, and each VOC associated with inflammation and worsen with recurring episodes leading to serious complication and end organ damage. So in prodromal phase of the sickle cell disease, it includes numbness, paresthesia, aches and pains, and sometimes asymptomatic. And patient reach peak pain and severity increase and anxiety. And in established phase, the patient maintain peak pain severity and signs of joint effusion and inflammation. And in resolving phase, pain severity decrease. So common timing for the onset of complication, it is acute chest syndrome and the relapse. So vaso-occlusion may be only the tip iceberg when it comes to the ongoing vaso-occlusion in sickle cell disease and the extremely painful events that last an average 10 days. And subclinical, this is a silent ongoing vaso-occlusion occurs systematically during the patient lifetime and potentially resulting in acute and chronic complication. So multicellular adhesion promote VASO occlusion and VOC, that's a vicious circle in the sickle cell disease. And initially, there is an inflammation and the cell activation, and the blood vessel of the patient with sickle cell disease are in a chronic state of inflammation because of activated endothelial cell of the blood vessel wall. Then it lead to multicellular adhesion. Then it lead to VASO occlusion and vaso-ocular crisis. It lead to end organ damage. So one or more VOC in a given year have been associated with increase of death at an earlier age. VOC were defined as a patient-reported emergency department visit and hospitalization and pain treatment in the 12 months prior to the enrollment. So vaso-occlusion and VOC can lead to end organ damage, multi-organ failure, and death. So damage to the brain, at least 25% of the patient with sickle cell disease experience a neurological complication in their lifetime. Then kidney, there is 18% of all death in the patient with sickle cell disease have been associated with kidney dysfunction. And in reproductive system, 35% of the men experience priapism and women are at increased risk of VOC during menstruation. And in lungs, 75% experience acute chest syndrome and 20% patient suffering from pulmonary hypertension. And liver, there is end organ damage due to hepatobiliary system is typically the result of vaso-occlusion with approximately 40% of the VOC affecting livers. So there is a multi-organ failure, that is a brain, kidney, reproductive system, lung and liver, and sometimes there is an early death. And sickle cell disease is a multi-system disorders that affect nearly every organ in the body, including heart, eyes, and the bones. So the practical approach for the sickle cell crisis, there's a good hydration, especially during the exercise, adequate sleep, temperature management, and avoid extreme cold, and avoid emotional stress. And the single and the long-term transfusion program can prevent these acute complication. And the potential side effect include transfusion reaction and iron overload. Transfusion are often challenging owing to the lack of availability of a safe blood. So the practical lifestyle approach can help to prevent VOC. There's a good hydration, adequate sleep, temperature management, and avoid emotional stress. So dehydration, cold, stress, and fatigue cannot be totally avoided in daily life. So these approaches are not disease modifying and are not being evaluated in a clinical trials. Role of blood transfusion in sickle cell disease. Blood transfusion play an important role in treatment and prevention of acute and chronic complications of sickle cell disease. And transfusion can either be a single procedure or as a part of a long-term treatment regimen. So single transfusion in case of acute chest syndrome, transient aplastic crisis, anemia, acute splenic sequestration, and pre-operative procedures. And short-term side effect of the transfusion, there is a volume overload, acute non-hemolytic reaction, and the long-term and a chronic transfusion indication in stroke, abnormal PCD, and multi-system organ failure. And the long-term side effect of the blood transfusion, allo immunization, hyperhemolytic transfusion reaction, and iron overload. The aim of transfusion is to increase oxygen carrying capacity, restore blood volume, prevent VOC, and reduce sickle erythropoiesis. Sickle cell anemia is the most common in African and American, and in India, highly prevalent in Aboriginal tribal area. There's a Mahar, Kumbi in central and Orissa in Chhattisgarh and Vidarbha, and in Gujarat, there's a Dahod and Godhra. Clinical manifestation of the sickle cell disease depend on either the case there is a homozygous or heterozygous. The presence of high fetal hemoglobin prevent manifestation of sickle cell disease during early month of life. Homozygous sickle cell disease usually manifests beyond 4 to 6 months of age with a chronic hemolytic anemia with moderate pallor and sign of chronic hypoxia. There's an exertional dyspnea and growth failure, signs of hemodynamic decompensation. There is a congestive cardiac failure, cardiomegaly, while older children may also develop gallstone due to excess bilirubin production. Moderate splenomegaly with or without hypersplenism, and splenomegaly frequently regress after 5 to 6 years due to this recurrent infarct. It leads to autosplenectomy due to repeated splenic infarct, and this is altered function predispose this case of a serious infection, and it leads to sepsis, meningitis, and osteomyelitis infection. By capsular organism, they are more prone to develop this infection. There is a pneumococci, H. influenza, and salmonella, and signs of microvascular ischemia and recurrent infarct, and it leads to clubbing, nephropathy, chronic leg ulcers, and recurrent epistaxis in sickle cell disease. Sickle cell nephropathy characterized by recurrent hematuria and hypostenuria and the loss of concentration capacity due to recurrent medullary infarct. Sickle cell crisis. In sickle cell disease, there is a hemolytic crisis, hyperhemolytic crisis, VASO Occlusive crisis, aplastic crisis, and megaloblastic crisis. Acute crisis episodes, which may be spontaneous and developed after hypoxic events. There is a fever, infection, dehydration, acidosis, and high altitude and extreme cold. It precipitates this crisis. And main type of the crisis seen in sickle cell disease are as follows. Vaso-occlusive crises are most common and usually spontaneous, and clinical spectrum, there is a sudden painful swelling of the hand and feet, and there is ischemic necrosis of small bone. There is a hand-foot syndrome, acute abdominal pain, and mesenteric ischemia, and cerebrovascular stroke, acute chest syndrome. There is a pulmonary embolism and sudden blindness. There is a retinal occlusion and priapism. There is a venous obstruction of corpora cavernosa and vaso-occlusive crisis precipitated by cold, hypoxia, infection, dehydration, and acidosis. Sequestration crisis with massive splenomegaly with circulatory collapse due to sudden pooling of the blood in spleen and are the most common in younger children, usually after acute febrile illness. It occurs in spleen, chest, and the liver. Hemolytic crisis. This is hemolysis usually accompanied by crisis. Hyperhemolytic crisis with a sudden and severe hemolytic reaction are seen in the cases with a coexisting G6PD deficiency, and aplastic crisis with a sudden bone marrow depression and pancytopenia are usually associated with parvovirus B19 infection. And megaloblastic crisis, the megaloblastic anemia following chronic hemolysis and chronic erythroid hyperplasia leading to folate deficiency and sudden arrest of erythropoiesis. Hemoglobin can be dropped markedly as much as 2 to 3 milligram gram 2 to 3 gram percentage per dl, and supplementation of folic acid is a mainstay of treatment. Painful abdominal crisis, vaso-occlusion of mesenteric artery leading to area of bowel dysfunction, and there is a severe abdominal pain and signs of irritation, and persistent bowel sound differentiate it from acute abdominal surgical exploration. It usually resolved in period of 3 days. Management of this painful abdominal crisis by bowel rest, maintain the hydration by IV fluid. Vaso-occlusive crisis, this occurred due to the obstruction of microcirculation. An obstruction of capillary of bone marrow causes ischemic necrosis and death of bone marrow and initiate inflammatory response, increasing intramedullary pressure, and clinically there is a swelling over affected bones with a severe pain and the tenderness seen in younger children. It affects small bone and hand and feet, it causing dactylitis and hand-foot syndrome, and child gets aches and pain. Management of this vaso-occlusive crisis, there is a hydration and analgesics. Avascular necrosis of bone occurs secondary to this vaso-occlusion of nutrient artery of the femoral head, humerus, and upper end of this ulna be affected, but severe disability more common in femoral head of necrosis due to the weight bearing. So neurological involvement include paresis, hemiplegia, monoplegia, and common age 3 to 10 years. It result of occlusion of major blood vessel in about 70 to 90% of children get repeated episodes. And the management of this is chronic transfusion regimen to keep the hemoglobin S level below 30 to 35%. Infection. These children are a high risk of infection. There is an encapsulated bacteria such as Streptococcus, pneumococci, H. influenza and typhus, and meningococci and Salmonella species. And they are risk of overwhelming infection, particularly if more than 3 years of age, with meningitis, septicemia, and pneumonia. So which are the long-term problem of sickle cell disease? Long-term problem of sickle disease are failure to thrive due to chronic disease, pigment gallstone due to hemolysis, Salmonella osteomyelitis, aseptic necrosis of hip, priapism pooling of blood within corpora cavernosa, renal failure, congestive heart failure, proliferative retinopathy, splenomegaly in infancy with autosplenectomy due to splenic crisis later on, and leg ulcer. Heterozygous sickle cell trait. It is usually asymptomatic due to mild vaso-occlusion, and manifestation may develop in severe hypoxia. High risk and family screening is vital for this genetic counseling. The mixed hemoglobinopathy usually have milder presentation except hemoglobin S beta thalassemia, which clinically indistinguishable with the SS disease. Which investigation carried out in case of sickle cell disease? There is a peripheral smear showing the characteristic sickle RBC, and there is a poikilocytosis target cell, nucleated RBC, whole jolly body cell, and signs of splenic dysfunction. And sickling test is a simple screening test to demonstrate the sickle cell disease suspected cases. And hemoglobin solubility test involve adding measured amount of hemoglobin into a concentrated reducing solution and turbid precipitate. It indicate presence of hemoglobin S. And hemoglobin electrophoresis is a confirmatory test which reveals the concentration of the various hemoglobin in hemoglobin electrophoresis. In sickle cell disease, there is an adult hemoglobin 0%, hemoglobin S, it is 85 to 95%, hemoglobin A2, it is 2 to 3%, and hemoglobin F, 5 to 15%. In sickle cell anemia trait, adult hemoglobin 55 to 60%, hemoglobin S is 40 to 45%, and hemoglobin A2 2 to 3%. And sickle's thalassemia, there is a adult hemoglobin 0 to 20, hemoglobin S 60 to 80, hemoglobin A2 3 to 5%, and hemoglobin F 10 to 20%. And SC disease, there is hemoglobin S, it is 45 to 50%, and all values in the percentage of total hemoglobin. Other investigation may reveal is a non-specific, there is the non-specific variant, there is a hemolytic disease, there is a moderate anemia, high reticulocyte count, hypercellular marrow with erythroid hyperplasia, hyperbilirubinemia, and antenatal diagnosis is possible at 12 weeks by DNA PCR study in fetal fibroblast. Management of sickle cell disease. So the preventions and early treatment of precipitating events, that is infection, fever, dehydration, acidosis, and hypoxia. And also high altitude, they cause this crisis. And supportive treatment in acute crisis, the fluid and electrolytes correction, alkali therapy to prevent acidosis, and the blood transfusion, and simple analgesic, that is paracetamol, and cold fermentation may use to reduce pain in a VASO Occlusion crisis. And treatment of chronic anemia, there is a repeated transfusion are generally not required except in a severe case and during the crisis. And folic acid supplementation are necessary in all cases due to increased erythropoietic activity. Preventive management in case of sickle cell disease. So preventions of infection due to this splenic dysfunction, due to this autosplenectomy, there is a pneumococcal vaccine, meningococcal, and H-influenza vaccine immunization. And children more than 2 years should receive penicillin prophylaxis from 3 to 4 months of age, as a current pneumococcal vaccine may be given only after 2 years. And surgery, the transfusion are performed pre-operatively for the major surgery to reduce hemoglobin S infarction fraction less than 30%. And anesthetic care is taken to keep the patient warm, well oxygenated, and hydrated, and pain-free, and acidosis avoided. The main treatment of this sickle cell crisis is a hydroxyurea. Hydroxyurea is a myelosuppressive agent to stimulate HbF, and somewhat it prevents hypoxia. So to reduce hospitalization due to VASO Occlusion crisis, and also reduce blood transfusion by 50%. And it is relatively safe and well tolerated in children about 2 years of age, except potential but reversible risk of bone marrow suppression. Typical starting dose of hydroxyurea 50 to 20 milligram per kg per day OD, which may be increased 5 milligram per kg every 8 weeks to the maximum dose 35 milligram per kg per day. it should be temporarily discontinued if absolute neutrophil count fall below 2000 and platelet count fall below 80,000 millimeter cube. So hydroxyurea is a mainstay for the sickle cell disease management. It induces production of hemoglobin F and thus reducing HbS polymerization. Hydroxyurea reduces neutrophil and reticulocyte count. It decreases neutrophil and reticulocyte adhesiveness and improving blood flow. And hydroxyurea reduces RBC hemolysis. And hydroxyurea causes release of nitric oxide, that's a vasodilators. So hydroxyurea use is associated with many challenges. So many patients still experience recurrent VOC while receiving hydroxyurea. So role of hydroxyurea, there is two blood markers. There is hemoglobin, fetal hemoglobin, MCV, leukocyte count increase. And clinical, there is hydroxyurea, there is a pain crisis, hospitalization, blood transfusion, and acute chest syndrome decrease. And this hydroxyurea, it prevents end organ damage to the spleen, brain, kidney, not evaluated. And due to hydroxyurea, there is a decreased mortality in sickle cell disease. And short-term effect of this hydroxyurea, that is a leukopenia, thrombocytopenia, and anemia. So vaso-occlusive crisis, the treatment is hospitalization, check the CBC, retic count, blood grouping, LFT, RFT, CRP, and blood grouping matching. X-ray chest if the respiratory symptoms, and ECG if chest pain, and there's a strong analgesia, usually IV opiates, and IV fluid 50% above the usual formula, and oxygen by CPAP if necessary in acute chest syndrome, and bed rest keep patient warm, and monitor closely saturation, pulse, blood pressure, respiratory rate, pain, and nausea, and IV antibiotic if infection is present or suspected, and transfusion if necessary. Multiple may be needed, and exchange transfusion if indicated, and this decrease this proportion of the sickle cells. And in severe painful crisis, the neurological damage, sequestration, sickle chest syndrome, and priapism, where the exchange transfusion is indicated. Newer modality for the sickle cell disease, there is a bone marrow transplantation, stem cell transplantation, humanized monoclonal antibody, there is a crizanlizumab, other HbF stimulating agents, there is a butyrate and 5-azacitidine, and HbF reducing agents, there is a DDA-VP and calcium channel blockers, and membrane stabilizing agents, there is a zinc, hemoglobin solubility increasing agents, there is urea and cyanide, and recombinant human erythropoietin, and genetic counseling, carrier detection, and antenatal diagnosis is essential in all cases to prevent further morbidity in family due to sickle cell disease. The newer modality, there is a crizanlizumab, is a first and a only targeted monoclonal antibody that works by inhibiting P-selective mediators and also prevent multicellular adhesion in sickle cell disease. Crizanlizumab give dose, there is a 2.5 milligram per kg, there is a low dose, and maximum dose, there is a 5 milligram per kg, and loading dose after 2 weeks another, there is a 5 milligram per kg, then maintenance dose, there is a 5 milligram per kg every 4 weeks, and each dose administered intravenously over a period of 30 minutes, and it is humanized monoclonal antibody that bind to the P-selectin and block any interacts with P-selectin by glycoprotein ligand. So P-selectin is expressed on a platelet and endothelial cell, and that means role of the selectin in multicellular adhesions. So normal erythrocytes do not adhere to the endothelial cell strongly and in substantial quantity because they are not known to bear selectin ligand or to bind the P-selectin. So cell-to-cell interactions should be multicellular and result in formation of vaso-occlusive clot leading to pain, hemolytic anemia, organ injury, and early mortality. So humanized monoclonal antibody, it binds P-selectin and block its interaction with its ligand, including P-selectin glycoprotein ligand. So role of P-selectin and mechanism of action of, so this statically, it significantly it decrease this VOC frequency, durations, and the severity. So efficacy, it is 45% reduction in number of VOC per year. More than 1/3 of the patient had no VOC, and 42% reduction in days in hospitalization per year, and delay time of the first VOC. Majority of the adverse drug reaction were mild to moderate, no increase in risk of infection, and only 2 patients discontinued treatment due to the adverse reaction. So VOC may be only the tip of iceberg when it comes to the ongoing vaso-occlusion, and multicellular adhesion promote vaso-occlusion, and VOC is a vicious cycle in sickle cell disease. And vaso-occlusion and VOC can lead to end organ damage and multi-organ failure and early death. And VOC have been associated with increased risk of death at earlier age. And VOC can be managed using hydration, supplemental oxygen, appropriate analgesics, and partial exchange transfusion. Sickle cell disease patient may avoiding seeking healthcare assistance during VOC because of stigma around opioid use, poor provider knowledge, and structure of their healthcare system and expense. There are forms of management, therapy, and preventive treatment, including blood transfusion, hydroxyurea, but there is an unmet need for additional preventive therapy, the preventions of hypoxia, acidosis, dehydration. Thank you.
Hello.
Hello.
Yes, sir. We have some questions now. So I'll be
Oh.
posting one by one questions in the chat.
Okay. Which question?
Yes, sir. I'm posting the question. So can you find the question in the chat?
No.
I've posted it.
No. Please.
Hello.
Hello.
Yes, sir. Can you find the question in the chat section?
No, I do not find.
So I will only read the question now. No problem.
Oh, okay.
Yeah. Which skeletal manifestations of sickle cell disease are caused by bone marrow hyperplasia?
Clinical manifestation. As clinical manifestation, the hallmark of the sickle cell disease is a vaso-occlusive crisis. Mainly it is a hemolytic crisis when any pediatric patient presented with pallor, pain and pyrexia due to certain precipitating factor like fever, infection, hypoxia, dehydration and acidosis, it lead to hemolytic crisis. And there's a different type of this crisis. So crisis, hemolytic crisis is a hallmark of this sickle cell disease. Different crises are hemolytic crisis, hyperhemolytic crisis, VASO Occlusion crisis, aplastic crisis, and megaloblastic crisis. Hello?
Yes, sir. We have one more question. Can changes in the body temperature trigger vaso-occlusive crisis in the sickle cell disease? Can changes in body temperature
So
trigger
whenever there is a crisis,
vaso-occlusive
this crisis occur due to extreme cold. So give warmth to the patient to prevent this crisis. This precipitating cause of this crisis in sickle cell disease due to the extreme cold. So keep the warmth to the patient to treat this or prevent this crisis.
So one more question now. What is the life expectancy of patients with homozygous HbS sickle cell disease?
What is the life expectancy?
Yes, sir. Of patients with homozygous HbS sickle cell disease.
So in homozygous sickle cell disease, if we are not treating the sickle cell crisis in time, or we are not using this avoid this precipitating factor like dehydration, acidosis, hypoxia, also certain vaccine for the infection. There's a pneumococcal vaccine, meningococcal vaccine, H influenza vaccine. So if we are using this immunization, also give adequate prevent or manage this crisis, so their life expectancy we can extend. If we do not treat this in time, then there is a sometime due to multiple organ dysfunction and early death. So we can manage or we can extend life up to 35 to 40 years of age and prevent this early death.
Now we have the last question. When are the patients with sickle cell disease at risk for convulsions?
Having convulsion, whenever there is any child having this crisis, and when it during crisis there's a 25% of this CNS system and it damage to the brain, and due to this hypoxia there is convulsion with sickle cell crisis due to hypoxia.
Okay, sir, we are done with all the questions now. And thank you very much, sir, for your valuable time and sharing important insights on the topic, sir.
Okay, thank you. Good day.
Yes, sir. Good day to you, sir. Yes. Sir, you can stop sharing now.
Okay.
And you can sign out, sir.
Okay.